thyroid overworking, and then this is the thyroid underworking. What was the second word to this? Coma, which makes you think coma, right? So this is what's going on with my teens right now. Isn't it a big please, don't we miss Zoom, that's for sure. The same thing happened yesterday too, so. OMFG. Alright, I will just power off and power on. Alright, we're looking good. Alright, you guys, is this still the drill we're doing? Okay, just making sure. Gee darn it, and did it again. I'll draw my thing first. We always separate out nursing because sometimes we forget that you can just reposition somebody. These are not repositioning things, but we can't forget the things like that. There's the unexpected here, right? I feel like I'm forgetting something. Kennedy, are you recording? Can I stop? I just don't want to waste your. You're good? Okay. I just don't want to waste your. You know what I'm trying to say, right? All right. I'll try a different tactic. I'll click join this meeting. All right, I will recheck that. That's being recorded, so this is the best I can do. I can't. I wish I could help technology, but I cannot. If I could control the entire world, I absolutely would. All right, what do you guys want to do first? AKI, since it's up there. Okay. So what does AKI stand for? I like that. All right. So if we think about AKI, acute kidney injury. So there are 3 different ways the kidney can be affected, okay? So what's the first way? There's pre. What comes to mind when you think of pre? I like that. Where would the blood clot be? No, because that's not what the answer on the test is going to be. Right, I'm sorry, I don't mean to do that. I'm trying to make you think like outside the box, right? I like it. So, anywhere from what? Oh, sorry, I just totally knocked you out. I just shut the door. I just think anybody's trying to work out loud. So anywhere from the aorta, right, down to the renal arteries, right? Anywhere there. So we can name a couple different spectrums. I also I like clot. I also think perfusion. Somebody with a blood pressure of 50/20, are they perfusing their kidneys? All right, so I'm going to write perfusion. Okay. So in low perfusion, if we're not, like, what does our map have to be to reach the kidneys? Like 70? I think 60 for the heart, 70 to 80 for everything else, that outside. All right, so what's the next thing that can affect our kidneys? Intra. What does that mean? Inside? No, not to be rude, but that's the answer I was looking for. All right, so what can happen inside the kidney? Give me some things. I know we used an abbreviation last week called ATN. Do You guys know what that stands for? Acute tubular necrosis. So, when you think that, think like kidney can't functioning, get the little tubules and the little things are dying inside, so we can't regulate things, that kind of stuff. Also think of your toxic renal meds. What comes to mind when you think toxic renal meds, things that are processed in the kidneys? There's a lot of fewer coming to my head, because ATN is not going to be on the test, right? It's the drugs that are toxic to the kidneys that are going to be on the test. NSAIDs, right? NSAIDs are processed in the kidneys. Drugs. Vanco is uber toxic to the kidneys. You should always check a B1 and creatinine before you do Vanco, right? You should. We don't, but you should. Like, there's real world and there's textbook world. Any other drugs that come to mind that are processed in the kidneys specifically? I love it. There's a drug out there, I'll take both names, I don't care, that we give to somebody prior to them going to an appointment with doc. So your patient's going off to the cath lab, your patient's going off to CT. What could potentially give them to protect their kidneys? Have you heard of acetylcysteine or Mucomyst? Yeah. So we could potentially, and that's to prevent this. Traditionally, it's also for that person that's borderline kidney failure, like their B1 is a little high, the create's just a little high. We just don't want that dye to hurt them. All right, so that gives you an idea with the last one. Post. All right, give me things that would affect. So name some anatomical things after the kidneys. What comes after the kidneys? I think only three. Well, I guess three. I don't know. Ureter. Yeah, bladder. Technically the urethra, but it feels like part of the bladder. I'm like, technically three, but all right. So what can happen in the ureter, bladder, or urethra? Stone is probably the most obvious one. I'm gonna say infection too, like. Can you think of like a bladder infection climbing up into pyelonephritis kind of thing? Let's see if, oh, she's working. She's flashing less. If you're getting texts, say Jen's having technical difficulties. I can't log into Teams, neither can Jen. All right, so who's at risk? Who's the patient? You work in the ED. Who is at risk for this? We can always write one disease down, right? Diabetes. These poor people can't catch a break. All right, so clot perfusion. Who's at risk to have blood clots and perfusion issues? I love it. We didn't even write uncontrolled hypertension, right? Like, because now we're completely spasmed off. Oh, that's right. That would be a really long spasm. But anything else? What? Is it still called CAD or is it ACS? Neither of those. Okay, I'll keep it CAD. I'm like old school Jen, no CAD, but I teach ACS, so I wonder if that's the new word. So coronary artery disease, right? That plaque could help. Like, all right, who's at risk for clots? We don't really have any clot people up here. I love it! Because these kinds of things are not on the test. These kinds of things are going to be part of your case study, right? So that's why we keep saying this. All right, people at risk for these kinds of injuries, contrast, we have our chronic renal patient. I don't mean like opioid, like drug overdoses, I mean like people on Vanco and stuff like that. So we can put like MRSA, because they traditionally are on Vanco, right? Acute tubular necrosis, chronic renal patient, diabetes, very similar. So research says us in the Midwest are higher risk for stones because of our diet. Something in our diet, I don't know, I've never been a kidney nurse, but there's some sort of high calcium, low acid in our diet that allows us to get kidney stones. They're also hereditary as well too. Like you just are not born with the right things. So we'll write Midwest diet. And what does that entail? A lot of beef. Not a lot of, I had a kidney stone once. I wouldn't wish it on my worst enemy. Wouldn't wish it. It's no bueno. Now you got away. Let's try again. All right, are we in? We are. All right. So when I had my kidney stone, I was pregnant with Dylan, and I just wasn't drinking. I had heartburn really bad, so I wasn't drinking like orange juice and citric acid type things, just because I was just gonna taste it again later. So that's but high citric acid. The doctor basically, he's like, why after you deliver, just drink a Mountain Dew a day? And I was like, ew. I don't like that to begin with. All right. So what kind of things is your patient going to present with if they have acute tubular necrosis? So we have a lot of things to talk about here. Is that me? Okay. Sorry, I'm like, I had them on last night, so I thought it was, and I don't care. So low BP, low LOC, flat, high creat, because then the kidney's not functioning properly. They're not going to feel like pain. They might feel flank pain, but you're going to see that labs change before you actually get to the flank pain. Here we're going to see and creat. Oh, can't spell. Sorry. History of Vanco, NSAIDs. Somebody said something else. Oh, we wrote contrast out. Stone, this is high pain, high pain. I haven't met a person yet who hasn't had pain unless once it hits, if it's in the ureter, high pain. Feels like somebody's stabbing you in the back. Once it gets into the bladder, pain is gone until it gets into the ureter, and then it's pain again. And then depending if you're male or female, males have the longer ureters, so they have pain for a little bit longer, where the woman's ureter is about an inch. So a little bit high pain. Potentially, we're going to use our fancy words. Hematuria, blood in the urine. I'm getting fancy, right? Gotta use medical terminology. Urgency. What's the fancy word for urgency? Oliguria? Yeah, is that something? Yeah. Urgency. Like they gotta go a lot because they're trying to expel. Okay. But these are all very vague, so you're really looking at those labs to kind of help you. And that's what I forgot. I forgot labs. Still trying to connect. All right. You've got your patient in, your doc asks what your triage assessment was. Their blood pressure was crap, their heart rate was high, they're a little foggy, maybe they had like cloudy urine. What kind of medical interventions can you anticipate for your AKI? And maybe even if you think about it, let's prioritize them because that's part of your case study, right? Or I don't know that you're having that case study, I'm just thinking a potential case study. Okay, so what if something's wrong with their perfusion? What do you expect? Their cardiac output is low. Their cardiac output is low, and their heart rate is high. So if their volume is low, what are you going to anticipate replacing the volume? Fluid, right? And you would start with a 0.9 or an LR unless your labs tell you differently. That's a whole nother scenario that we're not going to talk about. That's going back to F&E with Dr. M, right? Like, then we can talk about hypo, right? So fluids, traditionally your 0.9 or your LR is going to be your initial assessment. Potentially, maybe with a little bit of K. Again, you have to know what you're not saying, right? So many variables. All right. Anything else you would think of for what if it's this? What would you? Oh wait, then we're going to farm. That's my fault. Don't listen to me. We could. No, that's farm too. All right. You do A. All right, labs. The obvious too, right? Give me some other ones. Think about erythropoietin, think about infection, think about that kind of stuff. So what other kinds of labs, other than the obvious, what kind of labs do you want? All right. CBC. I'm gonna say, oh, sorry, I can't spell it. NP, because what if they're like in some sort of heart failure or something, like just to kind of get a good picture of them, right? So BN grab an obvious, right? Renal function. CMP, that's your electrolytes and all that kind of good fun stuff. This does not come with a mag. Just go ahead and order it. Your CDC is gonna have your white count in it. You may then need to have your doc add on a diff, but white count is fine because white count's gonna help us here, right? BNP just for, and then your CDC, your erythropoietin, and your kidneys, red blood cell production. See, it all comes back to mine. You're like, Jen, no. I mean, farm. I was getting ahead of myself. I was going to nursing interventions. Drugs you can anticipate your doc ordering for you. Heparin, if it's a clot, right? If you anticipate, they probably already went to their CT to get their CT. Heparin, low molecular weight heparin, that's just its little friend. Lovenoxine, all weight-based, so make sure you don't. My driver's license weight and my scale weight are two very different weights, okay? So make sure you're not asking their driver's license weight, we're asking their real weight. And I had a guy one time who's like, I weigh 190. I'm like, dude, my husband weighs 190. You are not 190. He's like 250. I'm like, I thought so. I'm like, these drugs are based on your weight. You want them to work right. Perfusion, we talked about fluids, right? Spasms. Oh, I'm going to challenge you on this. Starts with the C. It's in the antihypertensives. Well, the class starts with the C, not the specific drug. The class starts with the C. They're an antihypertensive, but we also give them pre-cath lab to help with any kind of spasm in cath lab. It kind of relaxes. Calcium channel blocker. I'm just going to write CCB here, just because I don't have a ton of them. So they do have vasodilator properties, so they're are a little twitchy. We can smooth that out. We could give, I'm just going to spell Eucamus. The other word is acetylcysteine, and I can tell you right now I can't spell that. And then you have to culture and sensitivity, but we're going to give some sort of antibiotic if they have an infection. Stones, they might go off for vibration stuff. I don't know. I just passed mine, but they could. But you have to culture it. So grab that pea while you can. Probably a clean catch. If you don't cath them, you're probably going to cath them because we are going to watch those I's and O's like crazy, right? Every sip of water. Make sure they don't bring in their McDonald's Diet Coke. You're watching every sip, everything that goes in, we're watching. Because this guy's off, right? What's another easy thing we can do to watch weight? We don't even have to wake them up. Take their daily weight, right? We don't need an order to do that. We can just do that. We don't need an order for I's and O's. We can just do that. You do need an order for culture and sensitivity, but you don't need an order to hand somebody a cup and say, wipe the floor. We don't need an order. And it can sit there on the sink. You can be like, hey doc, it's cloudy. And then they can send an order off. It's just things to anticipate. Like, that's what we are. We're little Boy Scouts. We're ready for any kind of situation. Girl Scouts, Boy Scouts, I don't know. I was never either, so I don't know. What else can we do? So go back to your fundamentals class. Can we do anything with mobility? Can we do anything with positioning? It doesn't say there's anything wrong with their oxygen. We don't assume, right? It's all, I guess if they're 50 pounds overweight in water, maybe that I think some oxygenation issues, and then that takes precedence over the kidneys. We could fluid restrict them if they're, not perfusing well. I mean, like, any kind of special diet we want these people to be on? Not necessarily. So when you did chronic renal failure, that was a chronic situation. The acute situation is a little bit different. We're definitely going to watch their protein. We don't want them to be like that bodybuilder or whatever. I know there's some sort of ratio, like you want X amount of protein for however many pounds you weigh or something like that. I don't know. But we're going to watch to make sure that we don't overload them, but we also need them to have reserves to heal. So not a ton of diet. Like if we see them bring in Chick-fil-A 3 times a day, we'll probably have to talk about sodium. But at this point, the fluid restriction, if that doesn't work, then we can go and sodium restrict them.
Question.
Yes, ma'am?
Why would you do something like a 24-hour? Like
That is, no, you're good. I like the question. So you could, when you do a 24-hour urine, I think more like when you get to SIADH and things like that. That's where I used to see, or like a creatinine clearance. And there is kind of, I would say more in their chronic stage to kind of determine where they're at. Like I feel like, and don't quote me on this, I feel like that's how we sometimes stage that as well too. But again, don't quote me on that. All right, let's try one more time. Nope, we're just not joining the meeting today. This is wild. All right. Patient passes out at home because their perfusion is so low. What are some complications? Unexpected findings, things you don't expect with this patient. I'm sorry. Yeah, I think complications. They don't come to the hospital. They don't get any of this treatment. What happens? Yeah, so they can go to chronic, right? What happens if somebody's kidneys shut down?
the rest of the system goes.
It's just gonna back up into the heart, which is gonna back up into the lungs, which then they're drowning, right? Then we're going into pulmonary edema, blah, 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 right? So I'm gonna write pulmonary edema, and then you guys are gonna remember that there was a couple steps in there, right?
Did you say that stroke or PE? Because it's a lot.
I don't see why not. CVA, pulmonary embolism. Oop, can't spell. Oh gosh. Well, if they don't come in and have their stone, they could see some sort of surgical procedure to get that out, right? If they don't get an infection, what could happen? Pyelo, and then they have all the, like, you have to go watch their heart if they get pyelo and all that stuff. So, seems fine when we write it on the board because we have all this stuff to pull from. But, like, just think about all, like, obviously you don't have time on your test to write things out that you would love to write out, right? But, like, kind of just pull through your head. All right, they do come to the hospital. You transfer them to ICU, they get transferred to med-surg, it's time to discharge them. Thank the baby Jesus, right? What kind of diet are they going home on? That sounded phenomenal. Like I just pictured myself at the pool. Kind of diet. So they're fixed.
Maybe watching sodium, yeah.
Yeah, we're gonna watch, right? Yep. Watch their sodium and water. We're not eating salty French fries 2 to 3 times a week. We can have them, but in moderation. We're gonna watch our fluid intake. We're gonna teach them how to check their blood pressure. And it's easy. Yep. Increase vitamin C, which is your acid, decrease calcium. If that's what they find out. They will patho the stone and see what it's made of, and then tell you to stay away from certain things. Traditionally, they're made out of calcium. Sometimes they're made out of this spiky stuff. They look like little, yes, and I can't think of the name of it. Teach them how to take their BP, right, if it's a perfusion issue. Teach them signs and symptoms of a DVT. If they're going home because maybe they're going home on enoxaparin, how to administer it. Nobody wants to. I even know diabetics who still years later hate giving themselves shots. So, and then they might potentially need to go for labs. If they go home on Coumadin, they're going for like weekly until they're, and then we can talk about vitamin K. You can still have vitamin K, just don't keep it consistent, right?
That was like when I was right at warfarin, just the INR and heparin is
Right? It's okay. They're not 13 years. When did I start teaching? 9 years of teaching, and it's very hard. And I struggled with it too until I started practicing, right? Warfarin, Coumadin, PT-INR, and always platelets, right? Because platelets are your clots. Heparin, PTT, and platelets. So platelets always go with both of them because your platelets are your sticky guys, right? And we're trying to kind of make those guys not so sticky, but we still need to have them just in case they fall and bonk our head, right? I think I've told this story, but I'm gonna say it again so it kind of sticks because it's a very exaggerated story that it happened. Lady came in to the ED with an INR of 10.8. What's a therapeutic INR? 2 to 3, right? 10.8. The clinic sent her over. I got her, and she's obviously bruised, right? And she's like, how long is this gonna take? And I'm like, we're gonna give you some vitamin K, we're gonna, maybe possibly give you some FFP, we're gonna like kind of see. And she's like, what's this gonna take? And I said, I don't know. I have a party to get to. I have a garden party at my house. I'm like, girl, you have to stay. Girl, you have to stay. I'm gonna leave. I promise I'll come back. I'm gonna leave. I promise I'll come back. And I had 3 doctors, 3 nurses. Please stay, please stay, please stay. Please stay. She signed herself out. I did my job, right? She got rear-ended at a stop sign. She died before she got back to the hospital. She got rear-ended a block away from the hospital, and she died before she got back to the hospital. What do you think happened to that brain, that soft tissue? Yes, so my guilt, right? I didn't do my job, I should have said different words. I'm like, no girl, 6 people came in and talked to her. I'm like, and that's a big exaggerated story. It doesn't happen often, but that's a big deal. And yet, like, it's a very untherapeutic. And I think, if I remember right, she had IBS, and so she was eating a lot of salad, and then her IBS kind of reared its ugly head, and so she stopped eating a lot of salad, so then her Coumadin was working on vitamin K it wasn't used to. So that's kind of how that worked. But it's just sad. This is a DVT. I think with activity, just So your DVT patients, they can't just lay in bed, right? They have to get up, they have to move around, that kind of stuff. So remembering what the question is asking, are we looking at a pre? Are we looking at an intra? Are we looking at a post? They're not terribly dissimilar, right? Little things here and there, but you have to know what the question is asking. And I think that's the hardest part, is deciphering what the question is asking. Picture before I erase? I do not care. You're welcome to, especially since I can't log into Teams. So while you're taking pictures, I will try one more time to log into Teams. My picture came up and everything. Oh God, I look terrible. Great. Oh, you can see too, even better. All right. Oops. HHS, sorry. All right, which one's type 1 and which one's type 2?
HHS is type 2, DKA is
Okay. Who works in the healthcare system currently as like a tech or a hub or something like that? Have you ever seen this diagnosis come through, right? Yes. How do I add people? Oh, I guess I just checked like that. All right. Sorry guys, I just logged into Teams because it wouldn't let me, so I apologize.
Oh, it's okay.
All right, so DKA and HHS. One is a type 1 diabetic, one is a type 2 diabetic, but because they're two different diseases, they're named two different things. Does that? Okay, so when you see one, they're both the same. Does that? Okay, so don't let the verbiage mess you up, okay? So, what does DKA stand for? Diabetic. Ugh. I swear to God. Okay. What's our patho? What is going on inside the body? So not enough is your type 1, right? Because the pancreas is a whack-a-do. Or your type 2, resistant to the insulin that they are making. So it's like, I always call it like the insulin is dumb. It doesn't know what to do. And not dumb as in, but it's like floating around in the blood. It's like, what's going on, guys? What's going on? You know, that person that you work with that's always busy but never gets anything done. That's insulin right now, right? We've all worked with that person. How are they always busy? But I'm always helping them too. I don't get it. But so the insulin is resistant. It's just hanging out in the bloodstream. What's up? What's up? No, I can't help you. I'm busy right now. Like it just doesn't know what to do. All right. So too much glucose. So what is their labs going to be? And I'm talking. What are these? Are these 120? No, these are 600, 700, 800. I call them like. I always call them like Aunt Jemima. I'm like, girl, I can pour you over my pancakes right now, right? 400 or up. These are not our 120s. These are our, oh my, when you get the blood glucose monitor and it says send to lab, you're like, oh shit. Let's do that again just to make sure, right? All right, so too much glucose, not enough insulin or resistant insulin, okay? So what happens? What's the body gonna do if it doesn't have enough insulin to burn the glucose? Because that's the insulin's job, right? Is to like break down glucose for energy, correct? So what happens? What's it going to burn instead? Fat, which the byproduct of fat is ketones, right? So burns. So burns fat instead of glucose, okay? So byproduct. So this is how the keto diet works. Please don't ever do the keto diet. It's just very, you can go low carb, but just don't go no carb. So what's same thing? You're depriving the body of sugar, so then the body has to burn fat for energy. That's all it is, okay? Who's at risk to get these diseases? Type 1 and type 2s. Don't overcomplicate it. I'll write this just so we're clear. Three P's of diabetes. That's the word I was looking for earlier. What does polyuria mean? Poly meaning many, urea meaning lot, right? Or urea meaning P, sorry. What's the other two P's? Dipsia. Y or I? I don't know. What does that mean? Lots of thirsty, right? So you're thirsty and then you're just peeing it right out. So are you retaining it? Nope. So they're dry? Yes. The last one. I like it, but no. I hear where you're going with it. I know where your brain's going. What's the last one? I'm telling Cheryl. I'm tattling on you if you don't know. I'm gonna tell Cheryl. No, I'm just kidding. Polyphagia. G, not S, G. S, polyphagia is your stroke patient, or I guess it'd be dysphagia, but G, gut. So what is this patient? Poly meaning a lot. What's phagia? Hungry. Cookie Monster. And they want sugar, right? Because the body is not breaking it down, so it feels like it needs more energy, but it really doesn't because your body is stupid right now. You weren't born with the right things, or your insulin decided to get dumb, right? There's more than this. What else? I like it. That's the ketones. That's the byproduct of the ketones. And you will be like, so you smell bad breath all day, right? Like, really? You can't brush your teeth when you're in the hospital? Second, and you know they cough right in your face the second you bend over to listen to lung sound, you will 100% recognize that fruity breath the second you smell it. You'll be like, oh my God. Because I was dumb and did keto for a while. I was at the dentist and they're like, are you diabetic? I'm like, oh. They're like, that's bad. I'm like, whatever, I would lose 20 pounds. All right, what else? Diabetes. What are you gonna assess? So we talked about them being dry. They're taking it in, but they're peeing it right back out, right? So what is their sphincter gonna be? Dry. Blood pressure, potentially low, right? So they would probably then be tachy. So there's a specific respiratory word that I want you to think about when you think DKA. Good job. I don't know how to spell it, so we'll do the best we can. You are welcome to Google it, because I really don't know how to spell it. I have no idea. Kuzmov. Describe. So this word's not going to be on the test, is it? You're not lucky enough for that. Emily is not nice. No, she's, you get what I'm saying, right? What describe this breath?
It's like hyperventilating in their abdomen and chest breathing.
And they're fast.
Yeah.
Deep and rapid. And I love the way you just described that. They're deep, so we're using all the muscles Don't do it because you'll want to pass out. So let's go back to acid base last year. I know. All right, why are they deep and rapid? You guys know I read it backwards at this point, right? Okay, so we are in some sort of metabolic acidosis, right? Kidneys, right? Okay, so why are we breathing deep and rapid?
They're trying to
Blow off CO2, okay? And I put it under labs on purpose, right? Those are labs, right? So does that make sense? Because this is not on the test. The scenario is, what are you going to do to reverse their metabolic acidosis? We are going to put a mouth breather on, have them breathe off their CO2, or let's correct this, and then their breathing will slow down, right? So whose moles is not going to be on there? Deep, rapid, accessory muscle use, that's going to be on NCLEX, okay? It's just not that easy, unfortunately, right? Okay. I erased something, medical intervention. All right, so we're gonna have a hard time splitting this in farm. So fluids, right, because they're dry. Weird, but we're gonna put a little sugar in their fluids because we're giving them IV insulin, and if they drop too fast, I know it makes sense if we think about it out loud, right? Like, why would you push D5 up? Because if we're giving them 20 units IV, they could drop from 400 to 300 and they might feel a little shaky, right? All right, so IV insulin, Q1 hour. Those are fun. I mean, they make your shift go fast, right? It feels like you're checking it every 10 minutes. Anything else? Are we missing anything? Why? I love that you said it, because you're not wrong.
because the insulin pulls the stuff into the cells.
Awesome. Probably not DKA. That is specifically, we're going to talk about that with a potassium imbalance, but I love where you're going. And also, we're dry, right? So that's going to be a concentrated potassium. So we have to be careful how we treat the potassium. Are we treating a concentrated potassium, and once we restore their fluid volume, it might be back to 4.0. Or maybe it's not. Oh, I was like, I don't know if he's asking a question or if it's just, that's okay.
I'm sorry.
No, stop, Josh, you're fine. I thought you were asking a question. I wanted to make sure you got, I didn't want to ignore you.
You don't keep her in the background.
All right, I know I wrote this ginormous. Are ABGs fair game on this test? Oh, we got time if you want. All right, like it, I'm trying to think, like, all right, labs, CBC, BMP, CMP, whatever you want to put, MAG, say it again, Kennedy.
Specific urine gravity, that urine stuff.
Yes. UA, probably gonna culture it. What does bacteria love? Sugar. I was practicing questions because I always like to be on my game for you guys, especially as you guys go into NCLEX, like I want to be on my game. And I got a question about an elderly diabetic patient. What would the first sign and symptom be? And polydipsia and polyuria were on there, so I was like, well, those aren't the answers, right? Because they're too similar, right? We always eliminate answers that are similar. The other one was something that I was like, psh, that's not even correct. So the last answer that was available was infection. And I said, oh, MFG, that's sort of critical thinking. I eliminated two because they were the same, right? And then the other one was clearly not correct, and I was like, so we're gonna try to end with some questions. so we can go through, like, talk through stuff like that. I'm gonna say this on tape, I don't know what test bank she uses, I have no idea, but we can practice test bank questions knowing that they will be similar, so. And she doesn't use all test bank questions, but we do because we are teachers, we are not test readers. All right, nursing interventions. We can talk about diet here. Complex carbs, simple carbs, proteins and fats, okay? They need all of them because we're going to be giving them IV insulin, so we're dropping them, right? But we can't drop them too fast because then they get symptomatic. So we need all the things. Probably try, they're in a hospital, they're not getting unprocessed food in the hospital, but you're not eating dirty food, but as clean as possible, as unprocessed as possible. So lots of fresh veggies, lots of fresh fruit, as long as they're not on reverse isolation precautions, like that kind of stuff. Lots of things to keep their gut going. So unprocessed foods are traditionally lower in sugar and lower in sodium as well too, because it doesn't have the sodium to maintain the preservatives. I'm gonna write ADA diet, and this kills me to write it because it's not great, but it is what it is. I just need to do some current research. Other nursing interventions. We let the patient with maybe we should write a change in LOC here. Sugar of 400, you're a little foggy here now. We let them get up and wander around. No, they probably have safety precautions. They probably have the different colored socks on, you know, when you see those colored. Ours were yellow, like how obvious is that? Like caution, caution. So, safety, we're definitely watching this person. We're also safety watching this person to make sure their family members aren't bringing contraband in, right? Maybe, like, I had a guy opened up his, under the bedside thing that goes over the bed, opened that up, filled with hobos. What are you doing with these? He's like, sometimes my sugar feels low. I'm like, your sugar is currently 625. You don't feel low. I'm taking these. And he was so mad at me, He's like, dude, we're never, we couldn't figure out why we couldn't get him down. We were tirelessly working and he was just staying in the 600s. Well, it was the hobos, right? I don't like hobos, but we distributed the wrapped ones to the nurses that day. I'm like, I'm stealing your food. Other nursing interventions, so let's think safety, turning and repositioning, not so much, unless they're completely schnockered, then you might have to turn Q2, right? Making sure they're eating appropriately. This is probably where we want to document what they ate, like 40%, 60%, that kind of stuff. We can list all the complications of diabetes here. All right, chronic renal failure, CA or ACS, I guess, not CAD, they would already have CAD. CVA, amputation, blind. All right, so we've head, eyes. We give gabapentin for it. Yeah, thank you. Kidneys, we talked about. Heart, we talked about. Peripheral vascular, we talked about. That's a general consensus of diabetic complications, right? Am I missing anything big? No, okay. But complications of diabetes, right? And then you have above and beyond, you can do metabolic acidosis, that kind of stuff. Oh, they are not on blood thinners anymore. Diet, ADA diet. So they're going home, they're out of the ICU, they're going home, their ketones are back to normal, their blood glucose has been stable for 24 to 48 hours, that kind of stuff. So ADA diet. Check AC and HS. Okay, so I think just this last year, insulin was actually affordable now, right? Before, I have a friend that's a type 1 diabetic. She had to go to her vet and have her dog diagnosed with diabetes, because dog insulin, that is the same as human insulin, was $30 a month, and her insulin was $3,000 a month. So she was taking dog insulin instead of human insulin, which is the exact same thing. But because healthcare is atrocious in our country, dogs get better care than humans, which I love dogs, I love animals, just as much as the next one, but good times, good times. Yes, she got dog insulin. But she could then afford groceries. It's sad. I want to stab somebody at the high levels of healthcare. So check your insulin, ACHS. Traditionally, so we're not going to stereotype these people, okay? This girl stereotyped when I first became a nurse. I was like, why am I taking insulin? And I found out it's $500 a month. I ain't got $500 a month. So talk to them about, can you afford it? Did you go on a vendor? That kind of stuff, okay? So we're just getting honest feedback, just like when you guys come in, like, I need to go on my test. Did you study? Like, where do we start with the basic questions, right? Can you afford your insulin? The answer potentially is no, and then we talk to the case manager, right? So don't stereotype and think they just went on a vendor. They most likely, they could have, but sometimes they can't afford their insulin. So check your sugars, AC and AHS. Activity as tolerated. Do you guys remember back when we learned about diabetes, managing your sick days, like when they feel a cold or the flu coming on, make sure they're checking their sugars maybe more often to keep their sugars more stable. When you are sick and diabetic, your sugars are like all over the place. You're high, you're low, you're high, you're low. So it's hard to cover that, right? Because you're running like this, you cover this, and then all of a sudden you're down here. So just managing those sick days. Meds, most likely insulin, maybe a Lantus. That's your long, like doesn't really peak, doesn't really like just kind of onsets, and then like it's usually Q12. We usually do Lantus Q12. Your Humalog, that's gonna like 15 minutes, so make sure the drug is at the bedside, right? Or you smell it on the floor and you literally go get it, give your insulin, and make sure they eat, and make sure it's something they're gonna eat, right? I gave insulin one time and then opened the tray. She's like, I hate meatloaf. And I'm like, I just gave you 20 minutes of insulin. Meatloaf. What's in the fridge, right? Like I had to hurry up and think, like, what can I offer her that has protein and fat in it? So just things like that. I just, with fourth semester DEMSN, we just went over all the insulin types just last week. So I don't know if she'll go that deep into meds, but just know Humalog is about 15, regular is about 30, the onset, and then they both are around like a duration of about 4 hours, which makes sense when we're doing AC and HS, right? But the Lantus is like a 12-hour thing, and then 70-30 is very similar to the Lantus. They are exactly the same. They are titled two different things because they come from two different diseases, okay? And I've been a nurse since 2004, so in almost 20 years of practice, I've never seen this diagnosis on a chart. And until I started teaching, I didn't know this existed. So now when I do get this, I ask them if they're type 1 or type 2. 95% of the time, they are type 2. So I'm not saying, but in a textbook world, if that comes up. All right, do we want to do these guys before we have 30 minutes left? Do we want to do these or ABGs? That's fine, it's your tutor session, not mine. I didn't let you guys take a picture. Good, all right, I'm sorry. Your soul book has a great, I have it in my office. Your soul book has a great little metabolic acidosis, like all 4 of them, and signs and symptoms and interventions. I don't know where it's at, but it's a great, it's a picture. It's not a part of the chapter, it's like a table. It's very nice and concise. And I don't know if Dr. Mensch gave you that last year or not. Because these are opposites, we're going to kind of, I want you to word coma mean to you guys? Like if your patient's in a coma, what do you expect? Lethargy, fatigue, not potentially unresponsive, right? Coma. So that's the picture I want you to come up with in your brain, okay? So what is mixed edema coma? What's the patho behind it? It's low, right? Because everything's low. Thyroid. Your thyroid is, so thyroid is weird. I think it's 1 to 4. You should know this because I've been battling it for years. Your THS is actually high. And that, you would think it would be low, right? But it's actually high because it's overworking trying to compensate. So your THS is actually very high.
You don't have to know necessarily values that are like memorized.
So,
Yes.
new net influx gives you normals, and I'm almost positive Emily does too. I don't remember the tutor students last semester saying they didn't get normals. So, but your THS will be high, but you still need to know that it's high. You don't need to know the number, but you need to know that when given a value and it's higher than your norm, that's what you're looking for. Low thyroid function. Picture your Hashimoto's patient, picture your hypothyroid patient. It's just a little bit more exaggerated. That's why it's an acute process. Who's at risk for this? It's not really looking like this. What are they gonna, okay, paint the picture for me. We already talked about fatigue, low LOC. What's their blood pressure?
Low. Heart rate is low.
I'm trying to think if I want to put that. Because if the blood pressure goes down, heart rate has to go up, but I don't want to put tachycardia because that is for thyroid storm. So we're going to leave heart rate off for now. Okay, everything's slow. Metabolism's slow, they're heavy, so we'll put weight gain. What else? It's a vital sign, and it's going to be low as well too. Their temperature is going to be low. This is the patient that you get their temperature and they're like 96.6, okay? Because everything is slow, even their temperature.
So slow breathing.
I'm mad about it. We'll see. I hear where you're going. I know what you're doing. You're trying to slow everything down. I'm not saying it's not slow, but I want you to think of fast for the other one. So, but I know where you're going. All right, so our patient is fatigued. Their activities, they get very fatigued very quickly with activity. So this is the patient. You might be checking their hemoglobin to see if they're anemic because they get fatigued just walking to the bathroom and back, and then they come back at 14 and you're like, oh, that's not the problem. So just paint that picture. They're bloated, they're tired, they get exhausted quickly. Farm. No. Levothyroxine? No. Synthroid is the brand name. Traditionally, this comes in micrograms, just to let you know. Their thyroid is high because it's overworking because it's understimulated. Boy, that just didn't make any sense. It was like 2 negatives making a positive, right? Cluster your care. Why? Yeah, they need naps. They need naps, right? So when you come in the morning, get your vitals, do your assessment, tidy up whatever you have to do. You're gonna come back an hour, we're gonna do your meds, an hour after, or a couple hours later, we'll get your bath. Like, it's very clustered care. And sometimes it's you kicking the family out because they need a nap, right? So make sure you're clustering their care. Good skin assessments. Make sure you're turning Q2, they're tired. Okay, their thyroid production. I mean, it controls a lot. This little gland does a lot of work for you, right? So what could happen if their thyroid just completely shuts down?
Would they lose like respiratory drive?
Correct. So decreased stress. That's why I wanted to put this here. Oh, 10. Okay. Like everything is just gonna slow. So think about maybe the elderly man or woman that lives alone and can't get themselves to the hospital. They're just gonna end up potentially passing away in their sleep, right? Unless they have a family member that's like, hey, I heard from the dead. Jeez, right? All right. We gave them their thyroid medicine. We got their TSH within their normal range. We think everything's under control. What are we going to teach them? There's going to be some medication teaching here, so we're going to have to pull back to farm. What are we going to teach them? What kind of diet are they going to be on? We're going to go high protein. Okay, sure, yeah. I know where you're going. No, because but we got their TSH fixed, so their metabolism should be coming back to normal. Okay, high protein just to make sure they maintain that muscle mass that they potentially lost while they were sick, right? All right. Activity as tolerated. Just because their TSH is fixed doesn't mean they're running a 5K this weekend, right? They have to build that energy back up. They are going to be fatigued for quite a while. They are going to be frustrated with their improvement, and then we just have to educate them. You're not going to flip the switch. If this happened over a period of time, you're going to get it back over a period of time. Meds. So they're on levothyroxine. How do they take this? Do you guys remember? Or is anybody on it? I'm on it, so I know how to take it, but
Same time every day.
same time every day, similar to birth control, right? Same time every day. There is a caveat though. I like it. Empty stomach. So I had to switch brands because my TSH kept climbing, but they kept raising my dose, and my TSH kept climbing, and I was like, I'm gonna tell you, I'm a nurse. Can we try a different brand? And so we had to call Kroger to see if they carried another brand. They didn't. So I had to go to Costco. They carried my brand, a different brand. So, and then my TSH came back down into the normal range. So it's wild. Like, Jesus, body. I tried to help you, but now you know my body's bougie and like Abbott over Pfizer. Empty stomach, 30 minutes before. A, right? A. We can talk about brands. That's a very specific. I don't think that would be on NCLEX, but that is something I do teach my patients. Like, oh, you've been on it for 6 months and haven't seen improvement? Why don't you talk to your doctor about changing pharmacies? So just those kinds of things. So I'm gonna do this in blue, okay? What's going on when there's a storm outside? Lots of activity, right? There's wind, there's lightning, there's thunder, there's hail, lots of activity. There's increase in activity, right? It's that easy. Not mad about that at all. It's the opposite. Our thyroid controls our metabolism. which is directly related to our muscle activity, our heart activity, our gut activity, all of it, right? It's the opposite. I always traditionally try to tell students to know one, and then when they ask you a question about the other, you know because it's the opposite. So you do you. I can't tell you how to study, but I will tell you the less you have to remember, the better. So, but again, I'm trying to show you the differences. So similar to when I teach a ton of antihypertensives. They all do the same darn thing, right? The ACEs we have to watch for a cough. The calcium channel blockers we have to watch for a little bit of pulmonary edema, just a little bit of pulmonary edema. But like beta blockers we watch for heart rate. Like just, they all do the same thing. We're just looking for those little differences. Don't make it too hard, okay? Oh my God, I'm blanking on the drug. It's not Synthroid, we might have to Google this. Spell it. METHI. Traditionally, we're watching, they're like these people. All right, so now what are they gonna have? A low TSH, right? Because it's overactive. Doesn't make sense, but that's how life goes. Their big thing is safety. So are they gonna be able to sit in bed? No, they're gonna feel like they're like hopping out of their skin, right? You're gonna be like, what's wrong with your ADHD today, right? They are going to be like ENC, their heart rate's gonna be high, they're gonna be like, and that's okay. Just make sure the oxygen tubing is, make sure the bed rails are down, make sure the covers are, they're probably not gonna need covers because they sweat in. Like, make sure they're safe, all right? So we definitely need to watch the protein with these guys, right? Because they're burning it. So high cal, high protein. They just need high everything, right? Because they're just burning it. I'm very jealous of these people. I smell like a cake and I do 4 pounds, right? You can get too hot. So we would put instead of the bear hugger, we would put the cool wash cloths in there, pulse points, axilla, groin, neck. They got too hot. People can get too hot. You get like vasodilation, then maybe not good perfusion to the core organs, like that kind of that. Same with cold, right? You're gonna then put everything to your core. So once we get them back to normal, they may not have that energy that they had during their storm. So again, as tolerated. If we get them back to normal, we'll probably keep an eye on them. Sometimes they need their whole thyroid out, and then weirdly they end up on levothyroxine as a replacement. I know that feels weird. So medical intervention could be that's right. That's it. Thyroidectomy could be the surgical intervention because we can't get it under control medically, pharmacologically. But so coma, slow, storm, lots going on. Yes, ma'am. Everything's just slow. I don't know who invented that word, but so we think about your everyday average patient versus this mixed edema coma patient. I mean, essentially, very, very fatigued, very, very napping a lot or sleeping a lot. Like, I can see where they came up with it. It makes sense. I hear it. All right, picture. All right, back to 15. Turn the TV on. right? Because,
I have a question.
ma'am, sorry, yes, sir.
With the labs over there with the THS, I remember seeing like something with a question where it actually has like the THS with like one of these disease processes, but it also incorporated your T3 and your T4, so you needed to know those values with
Oh.
those as well.
Okay. Add T3 and T4 to your study list. Thank you, Josh.
Yeah.
I do not know that right off the top of my head. I would have to look that up. Because T3 converts to T4, right? I should know this. I should know this. I should know this, but I don't. Every time we talk about this, my doctor's like, Jen, and I'm like, I just can't. Like, it's just not something that sticks. I'm sorry. It just doesn't stick. But, I'm sorry, you have to stare at me for a minute, Josh. Alright. Evolve. Source. There we go. Well, I have Evolve pulled up, but I have a UWorld account. What do you guys prefer? UWorld? All right.
No, so I emailed her, because her syllabus has different chapters and modules.
All right. My UWorld's not working. I gotta tell Lauren to re-up it.
So like the weekly, what it says read, so it's like 1 through 3.
Does she? Has someone told her this? Okay, I just want to make sure, like that.
Yeah, so it's like 1 through 3, 6, 7, like 16, 17, 18, 19. That's what I'm pretty sure.
Yeah, there's like 9 chapters.
All right, not something I would ever hide. All right. Oh, no, I didn't. All right. So look at my screen. Josh, hold on. I'll share my screen so you can see as well too. Share. This. Okay. All right. Josh, can you see like Saunders, the orange Saunders on my screen?
Yes.
All right. So, okay, guys. Here is. I'm opening up another tab. I'm typing in Soul, Chapter 1. I'm going to assume you're going over Chapter 1 on the first test, right? It's all that ethical, legal, poop, right? Like, you totally need to know it, 100%. Oh, look what pops up. The test bank questions. I'm being recorded. I'm not doing anything shady at all. Period, end of story. This is a way to quiz yourself. My God, if you can remember 9 chapters worth of answers, my God, you get applause from me, because I could never. So with that being said, do it. It's not cheating. It's not. It's a way to test yourself. Okay, I swear, Emily and I have talked about this for days. If a teacher is going to use 100% test bank questions, that's on them. If she uses those and doesn't change those, that's on her. Those are study tools. They are free on the internet. Do not pay for them. They are free. All right? Use it. I'm being recorded. It's not cheating. It's a study tool. Use it as such. Okay? And again, if you can remember how many questions, there's 24 questions in just the first chapter. Times 9, I'm not smart enough to do that, but more power to you if you are. So, not a cheating tool. It is a study tool. All right, so go into Saunders. I gotta look here because I'm too old. So, you guys have this orange book. I just saw this. Do you see this down here where it says Next Gen now? I don't remember that being there last semester. Now, Grant. Well, now there's only 25, but I didn't even know it was there. All right, so let's do study, content area, what's in complex care? Blood admin, IV, invasive devices. Oh, nothing more. Oh, look, there's shock though. That's coming up, right? All right, what did we just cover? Cardiovascular. Definitely endocrine could be one of those things we covered. That would be thyroid and DKA, so I feel like endocrine's a good place to start. Farm, we can always work on farm, right? Who can't work on farm? Endocrine, there's gonna be our thyroid stuff. And then because we only have 10 minutes left, we're just gonna do, oh, it's 301 questions. I'd say we're good. I don't know how to make it bigger. Is it this and the plus? There we go. And then, I'm sorry, I don't know how to get rid of it. A little better, right? So someone rephrase the question, so there's only one sentence.
What are some of those?
When should you check your sugar if you're low, right? Because it's asking what type of teaching stated by that a form of glucose should be taken if which symptoms develop, right? So we talked about the 3 Ps being high. So I always consider my low patient, I put quotes hangry. They're hangry. Everybody's encountered a hangry person, potentially themselves as well too, right? So signs and symptoms of low sugar is basically what it's asking, right? I like all those. I'm not mad about any of them. So definitely not 1, definitely not 6. We ruled those out right away, right? Ooh, we don't like the blurred vision, but that does go with DKA. So, all right, what's our rationale? Shakiness, palpitations, and heaviness are signs and symptoms of hypo, and the others would indicate need for food or glucose, polyuria, blurred vision, and fruity breath are hyper. And I gotta move Josh. Sorry, Josh. Oh, up here is next. Ooh, can we do 1, please? This could go with chapter 1, right? I mean, technically, this is kind of chapter 1 stuff in soul, like, you know, that, all that stuff that we do, we don't realize that we do. Are you gonna ignore them? No. What do you guys like? I like to, that's where I was going. My fingers don't work well today. Always read the rationales. We're not, just because we're trying to power through right now, but. I like 4. 4 is where my brain went, because definitely not 1. Definitely, they don't change the prescription of their insulin, right? They like that, you know, just like you wouldn't, correct? All right. DKA 950. I mean, come on, like that's Aunt Jemima right there. Like you could pour them over pancakes. discussed this, didn't we? So D50, that sounds like a lot. 240, 240 is still on the higher side, right? So we're just gonna push them up to 500, and then they're just gonna crash again, right? Because there's no protein, there's no fat to keep them. NPH, it's a potential, but I kind of like 3 better, but we'll see. We are correct. I think NPH will come later when we get them down into the words. But just like you did not do, and I did, I read into the question. I was like, well, nope. When I started saying that, I was like, no, Jen, go with your original response. You're not an idiot. I hear it. Good job. It makes sense, right? Kidneys are the first thing I think of when I think diabetes, right? And if you're trying to get more water and the kidneys aren't doing something right? That's just where I went. I don't know if that's the correct response. What's your rationale? Do you mind if do you want to expand on that, Kennedy?
Yeah, so hyperglycemic,
Good.
and HHS.
Good job. Awesome. I like it. You're looking for a wrong answer, which is difficult for anyone to wrap their head around because for 2 years you've been looking for right answers. You're looking for the wrong answer. Because during a crisis, during a sick event, their sugar is not necessarily low. Yes, they haven't been eating, and that's where we would go, but it doesn't tell you their sugar is low, right? Don't read into the question. Go with what they give you. If they gave you a sugar of 99, absolutely, but they didn't give you that information, right? Go with what's in the problem. What the hell is that?
You were also going to say that.
This is later, SIADH. Oh, look at that. You're like, I haven't even gotten to the bold word yet. I like that you're reading every single word. That makes me happy. I've missed more than a few questions in my life because I just skip over words. You like it?
Yes.
All right. So, what if this was a patient with kidney issues? Would you still say airway? No, not necessarily, but we know that our coma patient is fatigued and tired, and they may not be able to maintain their airway. Airway is only the appropriate response when airway is the appropriate response. If it's a broken leg, we're not maintaining an airway. So don't always, and I know that's not why you went there, but I'm just trying to, I had a student one time say airway, and I'm like, why? It's a broken leg. And she was like, it's always airways. It's on there. And I'm like, oh, girl. It's always airway if it's appropriate. So sometimes we do hit that a little too hard. we agree on one? One, not one, but can we agree on an answer? I apologize, because I saw somebody hold up a one. You like one? Are we, okay, that's fine. I saw you guys looking around, so I wasn't sure. No, so think about it. You have to get the sugar down for the acidosis to correct. You can't just go ahead and, you hear it now, but you can't just, you have to, that sugar is what, 5, 6, 700. You have to start correcting that, and then we can do other things while that insulin is working, right? But that IV insulin is immediate.
Like that one specifies an acute phase, like. is there
Oh, I don't know
a
that.
difference?
There are in the clinical setting. I don't think we teach phases. Yes, burn has phases, right? You have a resuscitative, restorative, like that kind of stuff. I don't think we teach phases in nursing DKA. There are phases in the medical model, but not the nursing model. I know. So, but what is your priority? Your priority is to correct the sugar, which will correct the acidosis, which will correct the breathing. So it's a whole chain of events. And I know exactly what you guys are saying. I know what you're thinking, because I thought the same thing. All right, use this. All right, Josh, we're done. Bye. So use this book, use UWorld. I just couldn't log in because I'm kicked out from Lauren didn't renew my contract. So use your book, use your soul little, once you figure out what chapters are what, and questions. Emily is a big proponent. She loves next gen style questions. So making sure, I don't know if Maryland is still on the table. I have no idea, but great resource, right? That University of Maryland. I don't know the whole web address. Great resource. Just use as much. She's a huge proponent for next gen though. So make sure you're getting those next gen questions under your belt, okay? Thank you for coming. Any feedback, if you hated it, if you loved it, just let me know if I'm hitting the mark. Even if, like, just to make sure, because I want to prepare you for the test, period, end of story, right? Like, so if it's not, if we don't hit the mark with Emily's teaching, just let me know and we can approach it differently, okay? But it's your study session, not mine. I talked, Laura Peppers.